Welcome back, everyone. Today we are diving into one of the most satisfying parts of a physical exam, the diagnostic tendon reflexes. I love this topic because it's basically like being a biological electrician. You've got your reflex hammer, you tap a specific wire, and you wait for the light to blink. If it doesn't blink, you know exactly where the circuit is broken.
Spoken like a true clinician, Dr. Khan. But while you're enjoying the blink, our students need to be laser focused on the specific spinal cord levels that these wires represent. For the board exams, it's not just about the movement, it's about the neuroanatomy. We're talking about testing the integrity of specific segments from the cervical spine all the way down to the sacral levels.
Exactly. It's the ultimate diagnostic shortcut. Think of the spinal cord like a massive apartment building. If the lights are out on the 5th and 6th floors, you don't go checking the basement first. You go straight to the breaker box for C5 and C6. So, Sarah, let's start at the top. When I'm tapping that biceps tendon, what exactly am I electrically querying?
The biceps brachii reflex is your go-to for C5 and C6 segments. When you tap that tendon in the cubital fossa, you're looking for a crisp flexion of the elbow. High yield point here. If that reflex is diminished or absent, we are looking at potential pathology specifically at those two cervical levels. Clinically, this is often due to a herniated disc or nerve root compression. And why does this matter clinically? Because if a patient comes in complaining of weakness or tingling in their arm, I can use that reflex to narrow down the search area before I even order an MRI. It's about efficiency. But we can't forget the back of the arm. Dr. Sarah, what about the triceps? The triceps reflex is slightly more complex in its segmental representation. The textbook standard is C6, C7, and C8. When you tap the triceps tendon just superior to the olecranon, you're looking for elbow extension. On an exam, if they describe a patient who can't push a door open effectively and has a weak triceps reflex, they are pointing you directly toward a C7 or C8 lesion.
I always tell my residents that the triceps reflex is like checking the extender cable. If that cable is frayed at the C7 level, the message to straighten the arm just gets lost in translation. Now, let's move south. The patellar reflex, or the knee jerk as everyone knows it. This is the big one.
It is indeed. The patellar tendon reflex tests the L2, L3, and L4 segments of the spinal cord. It's a classic. You tap the patellar ligament, the quadriceps femoris contracts, and the knee extends. If you're sitting for your step exams, remember L2, 3, 4, kick the door. It's a foolproof way to remember the lumbar levels involved.
I like that. L2, 3, 4, kick the door. But here's the clinical why. Imagine a patient who has trouble climbing stairs or feels like their knee is giving out. If I test that patellar reflex and it's hyperreflexive, meaning it's bouncing all over the place, that tells me the problem might be higher up in the central nervous system. But if it's flat, we're looking at those specific lumbar roots. It's how you become the doctor of choice in a busy neuro clinic by knowing which side of the reflex arc is failing.
That's a great point, Dr. Khan. Hyperreflexia versus areflexia helps distinguish between upper motor neuron and lower motor neuron lesions, which is a massive board exam concept. But we have one more crucial reflex to cover before we wrap up, the Achilles, or the ankle jerk.
The Achilles. This is the basement of the building. We're tapping the back of the heel to see if the foot points or plantar flexes.
Precisely. The Achilles tendon reflex specifically tests the S1 and S2 sacral segments. If a patient has a massive S1 disc herniation, which is very common, this reflex is often the first thing to disappear. For the students, S1 and S2, buckle my shoe, or in this case, point the toe.
Why does this matter clinically? Well, think about a patient with sciatica. They've got pain shooting down the back of their leg. If that Achilles reflex is gone, I'm not just guessing it's a nerve issue. I have objective, physical proof that the S1 nerve root is being compromised. I don't need $1 million machine to tell me what my reflex hammer just confirmed in 2 seconds.
And don't forget the brachioradialis for the upper limb as well, C5 to C7. Tapping the insertion of that tendon helps confirm the integrity of the mid-cervical segments through supination. It's all about building a map of the spinal cord using nothing but a small rubber hammer.
It's brilliant. You're basically checking the integrity of the system. We've covered C5, C6 for the biceps, C6, C8 for the triceps, L2, L4 for the knee, and S1, S2 for the ankle. It's a complete vertical scan of the human power grid.
Exactly. To summarize for the students, focus on the levels. Biceps is C5, C6. Triceps is C6, C8. Patellar is L2, L4. And Achilles is S1, S2. If you know those 4 pairings, you can localize the vast majority of spinal nerve root pathologies that will come across your desk or show up on an exam. Perfectly said. Clinical anatomy isn't just about naming parts. It's about using those parts to solve the mystery of why a patient can't move or feel. Keep tapping those tendons, keep asking why, and we'll see you next time.